Good afternoon, everyone. Thank you for joining us tonight. Welcome to the second webinar in the chronic kidney disease series. This one is managing chronic kidney disease in primary care. Before we continue, I'd like to acknowledge and pay respect to the Whadjuk Noongar people upon whose lands we are meeting today. I honour their elders past and present and recognise the continuing connection of Aboriginal peoples to their lands, waters and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. And I'd like to introduce Dr. Ashley Irish, who is a nephrologist at Fiona Stanley Hospital and also the Director of Nephrology at WA Country Health Service. So today's webinar is Managing Chronic Kidney Disease in Primary Care. This module was conceived and developed by Peak and it's presented by Kidney Health Australia and WA Primary Health Alliance. So we'd like to give thanks to the Primary Care Education Advisory Committee for Kidney Health Australia, or PEAK, who have developed and reviewed this education, and a thank you to our volunteer presenters. This is the Chronic Kidney Disease Management in Primary Care Handbook. If you want to get your copy, you can scan this QR code. I'm sure the slides will be sent out after this so you can access the QR code. So today's learning aim is to provide you with the tools to drive the early detection of chronic kidney disease in a primary care setting. The learning outcomes are as below. And without further ado, I will introduce Dr. Ashley Irish.
Right, thanks very much. I'm not used to doing these online ones and not seeing anybody in the room. It's good for you. You can have your glass of wine, as I just finished mine before. You can have your food, put your feet up on the table, stroke the dog, read the paper, or do anything else of interest. There's a lot of slides to come here. The message is actually fairly straightforward and simple. Some of this you're going to know, but reinforcement is good. And you're all aware that chronic kidney disease in Australia is a common problem, and various estimates, depending how you want to define it, say that up to 1 in 7 Australians are affected by kidney disease, and 75% of us have at least one factor increasing the risk of CKD. A bit scary. Chronic kidney disease is twice as common as diabetes. Again, very scary thought since we know how common diabetes is. Next slide. It's harmful. Chronic kidney disease identifies more than kidney failure. It identifies people at high cardiovascular risk. And in part, that's a mutual feedback loop where injury to the kidneys and injury to other organs often amplify each other's harm. And that people with chronic kidney disease are up to 20 times more likely to die from heart disease or stroke than they are to progress to kidney failure. And you might remember the old images of the pyramid of kidney disease, where a very large proportion at the base and a smaller proportion of regen stage, largely because people exit from death from cardiovascular disease. So many Australians die every year with kidney disease. And the number of people needing treatment for kidney failure has doubled in the last 20 years. And there's many reasons for that. The increasing prevalence of risk factors and the more acceptance of people onto dialysis as we all age that would have been denied treatment many years ago. The burden of CKD, we know, is higher in people who are socioeconomically disadvantaged, and particularly so in those who live in regions and in our Aboriginal population. Next. So the kidney team like to emphasise just how underestimated the prevalence of kidney disease is, and the majority of Australians are unaware that they have signs of kidney disease. As you know, many people will have impairment of kidney function, albuminuria and hypertension with minimal or no symptoms. And a large proportion of this is undetected because we aren't screening necessarily all of those at risk. Next. So when I started in kidney disease a long time ago, we didn't have any real treatments. And then ACE inhibitors came along, and then ARBs, and then not much else really for a long, long time. In fact, the last trial of that was about 20 odd years ago. And kidney disease was pretty much forgotten about because once you got on an ACE or an ARB, we didn't seem to have a lot more to offer. But you're aware there's been a revolution in therapeutic advance in this area. And now that if you can detect CKD early and treat it, you can do much better at retarding progression of kidney disease. And you can reduce this by as much as 50%. And the new treatments can slow the progression of kidney disease by up to 15 years if you start much earlier than waiting till they're already at stage 4 or 5. So what is chronic kidney disease? It's defined as a reduction in kidney function less than 60 mils per minute. It's present for at least 3 months with or without evidence of kidney damage, or more commonly, evidence of kidney damage with or without reduction in GFR. It's present for at least 3 months, usually meaning you've got to test more than once to find that. And the more important causes really are the presence of urinary sediment abnormalities such as albuminuria and hematuria, structural abnormalities which you might find on imaging, which most people would get, pathological abnormalities, and blood pressure really. And if you want to emphasize it, the urinalysis and blood pressure is still more important. So initial detection and diagnosis of CKD is to suspect it in those at risk, which is offer a kidney health check to people with much of what you'll see walk through your door every day: diabetes, hypertension, cardiovascular disease, a family history of kidney failure, obesity, smokers, previous episodes of kidney injury, Indigenous Australians, and elderly Australians. And here they want to categorise it, if you like, by staging the CKD by your GFR and the ACR, albumin to creatinine ratio. ACR is often preferred in testing, although I don't think PCR is completely unacceptable to test. You just have to understand the small difference between them. And sometimes the PCR and ACR together are actually more informative than one or the other alone. So I would tend to do both sometimes. But the important implication is that if you've got impaired kidney function and you've got albuminuria, then you stage that and that increases your risk. So for each increment in ACR and for each decrement in GFR, you're going to add your risk significantly. So this is one algorithm you can use. And then you can stage it according to GFR level and the ACR level. And the red group is clearly the highest risk, which need the most immediate action and have the highest risk of progression, complications, cardiovascular disease, and death. The green are people who may not have CKD unless there's demonstrated abnormalities of structure or blood in the urine. And we do see a lot of particularly elderly people referred to as reductions in EGFR that don't have an elevated ACR. And often we don't take into account age-related modification of EGFR. This assumes that EGFR doesn't vary according to age, which isn't quite correct, as we know. You will lose about 1% of GFR per year after the age of around 40. So some consideration of that sometimes needs to be considered before you think about referrals. On average, though, you could see that if you've got a GFR at stage 3A and you've got moderate or significant albuminuria, you're in a very high risk. It's interesting that for any level of kidney function, though, the ACR is actually probably more important, as it tends to predict complications and progression. Now we'll get to ask a question, which is you're going to answer in the chat room, I believe. So this is one of those questions. I'm not sure who wrote this one, but what key management strategies can be implemented in primary care to manage CKD? Slow progression, reduce the proteinuria, keep your blood pressure low, reduce your cardiovascular risk, avoid further damage to the kidneys. Oh, don't do anything, because we can't do it. Bit of an odd question, this one. So I think, what's the answer here? Fairly straightforward. Should be fairly controversial. If you choose F, you need another drink. If you choose anything from A to E, you're doing all right. So the answer is, of course, all of the first 5. And you might be aware the new targets for blood pressure are actually lower than they used to be. It used to be 140 on 90. Now it's 130 on 80. And some people would say the lower the better, so you don't stop. But all of those targets are to slow the reduction in kidney failure, reduce protein, keep your blood pressure low, avoid further iatrogenic or other complicated injury to your kidneys, and lower your cardiovascular disease risk, which is much more significant in the patient with kidney disease. So color-coded action plan. I must say I don't use these. I suppose because I do this every day and I don't need color coding, but this is quite busy, complicated slides here, I think, and these are probably best referred to later, but they're trying to give you some idea of what you should be doing and how often you should be doing it and measuring the outcome, what you should screen for. And a lot of what you see there is going to carry over to the next phases anyway. And it's always going to be the similar story. And some of this will be summarized later in some other slides, but management strategies might include how often you see someone, your targets, and then the positive lifestyle stuff, which is increasingly encouraged but often not taken up by our patients who prefer to have a GLP-1 agonist to lose their weight rather than exercising and restricting their food intake. Right, next slide. So the orange one adds something more to that. Again, it says you should review patients more often. You should be looking out more early for the complications, and you might need to make adjustments to certain medications as their kidney function declines. And you might need to consider appropriate referral to a nephrologist if there's concerning features in this group. It still means that largely this falls into primary care. Interventions are still, this is mainly going to be a GP practice one where you might intensify your treatments, apply them more rigorously, and follow up more often. Red means call the fire brigade, I presume, and start to panic. But here we're getting concerned that they've significant loss of kidney function. They have many risk factors for progression, such as uncontrolled blood pressure, high albumin levels, clinical features that might include symptoms now, edema, breathlessness, itch, change in appetite. They might be early warning signs of concern. And their cardiovascular risk remains very high. So you might want to focus in on these patients more intensively, and mostly they're going to be required to have specialist referral within their checklist in order to consider how their kidney failure will be managed. So this is a common one that comes up. The patient will ask you, but doc, what can I do? What can I eat? So what dietary changes could help preserve kidney function? Well, nutrition and diet, lifestyle modification. I think in the general practice in our specialist rooms, we don't often have time to significantly run through this in great detail, but I just tell my patients if you're eating healthy, and it would be a good diet to manage your whole of life concept, which would be a balanced diet with an exposure to all of the healthy vegetables and fruits and things identified there, reduction in your carbohydrate and your fat intake, looking to get rid of the empty calories from your sugary drinks, and the salt intake, often overlooked because most patients aren't aware of the role of salt, that it comes in every packaged and processed food, whether you like it or not, even in the low salt ones. And most of our older population are on the meat and 3-veg diet, which they'd liberally add salt to. So that's one that's often overlooked and has significant benefits if you can restrict salt intake. And then the cheap but ultra processed foods, which are empty calories. So there's still benefit to be had in this. Most patients tell me, but doc, I don't eat anything. I don't understand why I'm overweight. So you probably hear the same.
Dr. Irish, someone's commented lower salt Mediterranean diet and DASH.
Yes, yeah, DASH, that's true. Yeah, that diet has actually been shown to have benefit. And yes, it's very hard to get people to adhere to strict salt restriction though. And there is some controversy about how much it really adds, but I think I personally still emphasize salt restriction because most of our diets are heavily overweighted in salt. And when you're giving patients diuretics, to remove salt in the first instance, if you could reduce their salt intake, you'd often get just as good a benefit. Alcohol. And I won't just mention I had a glass of wine, but yeah, we get asked about this. Strictly speaking, alcohol doesn't harm the kidney. It harms your liver. It has other metabolic effects that are clearly disadvantageous to general health. I don't get too carried away with alcohol warning, and I'll probably get censored for that. But clearly, for some patients, excessive alcohol is a cause of hypertension, atrial fibrillation, and other cardiovascular complications. So you should certainly know how much your patient drinks and counsel them if you think that's contributing to a poor health outcome for that individual. Again, a sort of common sense approach. Most patients think that going for a walk around the block with the dog is sufficient exercise. Moderate activity, you really need to raise the sweat and get your heart rate up. And most of our patients, I don't find in general, particularly inclined to want to do this later in life. They've often got arthritis and restricted mobility, but encouraging them to keep active is still very important. And the use it or lose it motto is important. And we should encourage them to keep active. Any form of activity is better than sitting in the chair and watching the TV. So, yep, I bring it up and I try and encourage patients to be more active, and we should all keep that in mind. Yeah, so we see a lot of overweight patients, very overweight, and it's true the obesity itself contributes to the high blood pressure, to hyperfiltration in the kidney, to sleep apnea, to knee arthritis, lots of other complications. And you can develop that just from proteinuria, just from hyperfiltration through the kidney. And the central obesity around the abdomen seems to be more important. And this is where the GLP-1 agonists are perhaps going to have a great deal of change in order to help people lose weight. Losing weight helps their blood pressure, it helps their mobility, it helps them to exercise more, it helps them feel better sometimes, and it seems to have profound cardiovascular and renal benefits. You've probably heard of the 4 pillars, and this is going to target some of the concepts now about pharmacological interventions to reduce the progression of kidney disease. So, is there a difference between angiotensin converting enzyme inhibitors, which were the first drugs introduced that showed a benefit to kidney disease, or angiotensin receptor blockers, which came quite a few years later? Which one is better? Does it matter? Are angiotensin inhibitors better? So the answer is probably nothing, not really any difference, but they've never been kind of done head to head in a sense to determine that. And the way the trials ran was that the ACE inhibitors came first, and then when you get a new product, the ARBs came in and they were trialed in a different set of patients. Both seem to lower proteinuria and retard progression of kidney disease. And they mainly were tried in diabetics, and then there was a couple of trials in non-diabetics for the ACE inhibitors. But essentially, one or the other is thought to be equivalent. And whether you start with an ACE or an ARB probably doesn't really matter. I must say I tend to use ARBs now more than I use ACE inhibitors, mainly because I just can't be bothered asking people about whether they get a cough with the ACE inhibitor. So I tend to go with an ARB, and I find I can titrate something like Kanzasartan from 4 to 32 milligrams more easily than some of the others. And they tend to come combined with some of the other products, but I don't think it matters which one you really choose. So the new hypertension target is targeting blood pressures below 130 and 80. And there's quite a number of trials that show that even in the elderly, that seems to be safe. I still get nervous with the 80-year-olds trying to get their blood pressures down and having them fall over and break their hips. But in general, the philosophy is the lower the blood pressure, the better, and certainly less than 130 and 80. And it almost always takes several medications to achieve this. So 3 to 4 drugs is pretty standard if you want to achieve that. So blood pressure reduction, ACE inhibitor or ARB should be the first line for all patients. There's very few patients who can't tolerate it or are allergic or have a reaction to both. I still see about a small percentage of patients referred with kidney failure who are not on an ACE or an ARB. And the reasons for this sometimes are hard to elucidate, or they're concerns about potassium. That shouldn't be such an issue anymore, as we've got access to the drug Patirama or Veltassa, which is able to be used to maintain potassium balance in patients on an ACE or an ARB if their potassium rises above 6. So reducing the blood pressure is still the fundamental target we're aiming for initially. We should add to lifestyle changes, to weight loss, to dietary restrictions, etc. And we have to accept that hypertension is often challenging to control, and multiple medications at maximal doses are often required. So general ACE inhibitors and ARBs have a reversible reduction in kidney function. They trick the kidney into working less hard. I tell my patients, well, if you've only got 3 or 4 cylinders left in your 8-cylinder car, and if it wants to run as like it's still got 8 cylinders, it's going to burn out faster. So I'm trying to slow it down. And I tell them the albumin is the oil leak that's telling you the engine runs too hard. So you want to see the reduction in GFR when you start the agent, and you want to see that it's associated with the fall in albumin, because then it tells you you've achieved the outcome you expect. I've reduced the intracapillary glomerular pressure, I've reduced the risk of progression, and albuminuria falls. It says to use caution if the baseline potassium is greater than 5.5, as yes, most patients will show some rise in potassium on them. Should you check the EGFR within 2 weeks of starting therapy? I'm not sure, actually. I probably don't. I might check it at 4 weeks. And I expect to see some reduction in GFR. And the reduction might depend on what drugs you're combining with. If they're on a diuretic, you'll expect more effect than if they're not. And it depends what your dose you start on, and depends what baseline creatinine you start from. So some of these values, you just have to individualize and personalize the response. But in general, a substantial reduction in GFR, you might want to reconsider why that is. Perhaps stop it, reintroduce it at a lower dose, and re-estimate its effect again. And if you get the same effect, yes, you might want to consider referral. The old idea of the bilateral renal artery stenosis doesn't seem to occur as often as people used to think. Next. So prescribed medications to slow cardiac disease, CKD progression, and reduce the cardiovascular risk. So if you're going to start with your ACE and ARB, almost certainly the next measure is going to be your SGLT2 inhibitor. The statin and ezetimibe is part of the cardiovascular risk profile. The point at which that might be started would depend on, again, individualized risk for their lipid profile and their risk profile, which there's some online calculators I think they give you in, or you might estimate it from the family history and their individual risk. SGLT inhibitors are virtually mandatory for virtually all patients now, and the prescribing restrictions have been relaxed so that you can go down to eGFRs of 25, and the earlier you start them, seemingly the better. Again, there's very few people who you would be not aiming to prescribe, except those who have the restrictions on cystic kidney disease and vasculitis, for example. But they're very important, and they should be almost seen as equally important now as the ACE and the ARB. You want most of your patients on that combination, whether they're diabetic or not. And then for the diabetic patients, you have the additional therapies here, the non-steroidal mineral receptor antagonist, which is finerenone. And it's licensed for use in people with type 2 diabetes, who've got albuminuria. And it says not to initiate if they're less than 25 mils or when potassium is greater than 5. So I think that would be a specialist decision. We sometimes do it despite what they say, but probably for you safer not to do so. And the GLP-1 receptor antagonist, Trulicity and semaglutide, also have very powerful effects on kidney function and cardiovascular risk. So that's considered the 4 pillars, and with the statins chuck in there as a sort of 5th pillar, if you like. So if you're a diabetic patient, you'd like to see them on all 4. If you're non-diabetic, you'd want to be on at least the first 3. statin therapy. It's shown to have benefited in people with CKD not on dialysis, and so that's the point at which intervention seems to have been shown to benefit. For patients on dialysis, it doesn't seem to have the same effect. That message has never got through to our cardiologists who don't believe in it. But putting aside the controversy, I think patients with CKD progressing benefit of statin for cardiovascular risk prevention is strong in the high risk groups, plus or minus use of ezetimibe. Which statin you use, you need to be, I wouldn't go straight to rosuvastatin 40. A lot of people don't understand that that dose is actually been shown to be associated with impairment of kidney function and albuminuria itself. So you might start with one of the older ones, simvastatin or atorvastatin, before you need to switch to rosuvastatin. I know the cardiologists only seem to have one drug in their armamentarium now, and it's always 40 milligrams of rosuvastatin, but I don't suggest that's the appropriate starting point. Yeah, so the SGLT2 inhibitors, I think that shows you that you're allowed to prescribe them more broadly. So those patients with or without diabetes who've got an eGFR of 20 to 45 can have it regardless of ACR, and those with the eGFRs somewhat above that still have to have the ACR of 22.6, and they're meant to be on an ACE or an angiotensin receptor antagonist, and can be prescribed by our nurse practitioners. Most people find a way to prescribe them for that high risk group, and the broadening of the approach means that I think it increases the eligible risk population by something like 70,000 or a couple of 100,000 patients can benefit from this. It's extraordinary how cheap these drugs are, compared to all of the cancer drugs that have been introduced. This drug is super cheap. And the drug companies must have decided that the population use was such that they wouldn't need to put a mega price on it. And when it first came in, they didn't realize it was going to be used outside of diabetes either. So between ACE and ARBs and SGLT2 inhibitors, you've got two highly effective, super cheap drugs. And it's quite important that we take advantage of that. And even if you technically can't qualify, paying for the drug is not expensive. So most patients can get this. All right, which of the following about SGLT2 inhibitors is true? And you're allowed to choose multiple options, hint. So this is reasonably well known now. Go for the answers. Yeah, so SGLT2 inhibitors predictably cause a reversible drop in kidney function. I think reversible means you stop the drug, it would return to normal, and the effect plateaus out after a period of time. And then the preemptive reduction of diuretics or antihypertensives is recommended. So if the patient's already on a diuretic, I agree, because there's an osmotic effect from the SGLT, they're going to lose a little bit of fluid and weight. You would want to withhold the diuretic while you introduce the SGLT2 inhibitor and then review whether it's the reinstitution of it is necessary. You may want to reduce the dose of ACE or ARB. But they will all show some sort of drop. So measuring it to show it occurs in this situation doesn't help you, and it wouldn't be an indication to stop it. It just confirms that the drug's achieving the effect it's meant to do so. And it does this in a bit like the way ACE inhibitors does by altering the way the kidney senses sodium balance and the way the efferent arteriole across the glomerulus contract and constrict in order to maintain blood flow. So yes, they would cause a reversible drop in eGFR. You don't need to check to that. And they do cause the osmotic diuresis. So you would want to restrict the diuretic use. So finerenone, which is a non-steroidal mineralocorticoid antagonist specifically developed to get away with the hormonal side effect profile that we know with spironolactone, for example, is highly targeted now to treat aldosterone activation in diabetics. It's being tested in non-diabetics, and almost certainly is going to be like the SGLT2 inhibitors, where it's shown to have a similar effect in non-diabetic kidney disease. It was used over a wide range of GFR and proteinuria levels, and it's meant to be add-on therapy for both ACE and SGLT2 inhibitors. Again, it will show a predictable drop in eGFR and almost certainly some degree of serum potassium rise. So it's thought to be, you should be cautious about your potassium. If it's already above 5, you'd want to be a bit cautious its introduction. The dose is 10 to 20 milligrams. Sometimes I just start with 5 milligrams just to assess the potassium response and then gradually adjust it upwards. Clearly, you can't use it if they're already on or have an indication for another spironolactone, which the cardiologists still use quite a lot. And if you're a female, the hormonal effects are not so profound. So you may choose spironolactone in women, for example. But where it's probably still the least used add-on drug for CKD prevention, and we should be more pushing towards getting our patients on this as part of their pillars of support for the diabetic patient with kidney disorder. So a lot of medications are excreted by the kidney and need dose reduction as eGFR falls. Some should be avoided because of their accumulation effect or complications. There's quite an extensive list there. Some of those are not in widespread use and others are. One of the interesting things that you'll start to learn about is pharmacogenomic profiling, not part of the presentation here, but the Westerns and I think CliniPath will offer pharmacogenomic profiling for your patients, which allows you to predict their individual response to many of these drugs, not just from kidney function, but from their genetic predisposition. And we use that quite a lot now in practice to determine patients who say they're intolerant to statins, for example, or have other side effects. Quite useful. It's not expensive. It's about $170 for a test. It gives you a lot of detail. There's quite a list of medications there you need to be aware of that you may want to avoid, reduce, or be aware of accumulation. Avoid nephrotoxic medications. Yeah, we've got to be careful of some of the terms we use there, but those that can affect kidney function and CKD. I don't think you're going to be prescribing too much lithium to these patients or aminoglycosides. Non-steroidals and COX-2 inhibitors get a bit of a bad press, and sometimes we're cruel to patients and deny them that in the early phases of their kidney disease. So I think if they've got a normal eGFR, telling a patient you can never have a non-steroidal or COX for even a few days for their arthritic pain can be a bit mean. But it's a problem when you combine it with all the other, with the ACE, the ARBs, the spironolactones, and the diuretics in heart failure. That's when it's a problem. So, and then you've got other drugs that you need to, on a sick day, you have to be cautious. So the sick day rule tell patients not to take their ACE and ARB and SGLT2 inhibitors when intake is off. They're vomiting, they've got diarrhea. And that's important that they need to understand they don't resume them until they're well again, and they may need to stagger the reintroduction. Yeah, this is a challenging one. It's probably, again, we deny patients sometimes reasonable exposure to investigations that are going to help their management by concerns about nephrotoxicity from contrast. And it's a controversial area because the contrast risk is actually quite low. And it's a problem mainly when patients are sick, and it's not so much the contrast, it's the illness behavior at the time. So in hospital, we have 6 shocked patients. They don't do well with contrast, but in the well ambulant patient, using contrast can be considered at different levels of eGFR. But it depends on the pressing need for that imaging test. If you really don't need to do it and it's not going to change that patient's management, why expose them to any risk? But if you're concerned the patient has cancer or some other life-threatening illness, then exposure to contrast agents is still necessary. And if you're in doubt, you might want to refer them for consideration. But we would not prevent the patient having reasonable tests for investigation if that's part of good clinical care. Okay. I think you just got told the answer for that, but there you go. What would you include in a sick day action plan for an individual with CKD? And what is a sick day? You know, what is a sick day in a way? There you go. Sad man's. Not sure who came up with that. Yeah, so people with advanced kidney failure are at risk for acute on chronic kidney injury if they continue to take their usual medications during periods of illness, which is typically reduced intake, vomiting, diarrhea, or severe respiratory infections. And some of our patients continue to adhere to their strict medication despite this and can end up quite ill. So these medications can safely be withheld or reduced during illness and then progressively reintroduced on recovery. And there's some information there available on the Kidney Health Professional Hub and in your CKD handbook. It's an interesting one. I haven't had this before. Contraception and pregnancy. Again, having a child with chronic kidney disease requires some careful consideration about the risk and benefit. Then again, we shouldn't deny women access to supported care for pregnancy, but they need to be advised about the risks to the fetus and the mother. And some kidney diseases have low risk and some have high risk. Those with high risks tend to be those with more progressed disease, higher blood pressure and higher proteinuria. Yes, and your fertility does tend to decline as your CKD progresses, but you can still become pregnant. And unexpected pregnancies, like all unexpected pregnancies, require careful consideration and discussion. Contraception, again, should be managed on the best principles. I don't think you have to avoid hormonal contraception, for example. And if it's just better to have the most effective plan for that patient. If the patient wants to become pregnant with CKD, best to get some advice and have that supervised. Considerations in older people. Depending where you want to draw in the line, but you have to understand that eGFR declines as people age, and an eGFR of 55 in an 83-year-old woman is fine. If she's got blood pressure and you're treating it at minimal albuminuria, this is not necessarily dangerous CKD. It's age-related aging nephrosclerosis. Patients with advanced kidney failure later in older life, the decision whether to submit them to dialysis has to be individualized, and it's a palliative treatment. Essentially, you may or may not extend their life. They'll spend a lot of time committed to a complicated treatment that spends a lot of time in hospital, and many patients need to fully understand what they're getting into and often stumble into it by accident. So we don't deny dialysis to elderly patients. We probably treat more of them than we should, with limited and reduced quality of life. But they're decisions best made through relationships with patients over many years, so you can discuss with them and their family what benefits you may believe comes from offering them dialysis. So, treatment summary. Parameter, blood pressure. Probably the only slide you really need here, actually. But yes, blood pressure, you want to treat it to target. You want to treat it with the key medications that are listed on your right. You want to reduce the proteinuria. The current therapies often reduce proteinuria by more than 50%. And you would expect a minimum of 30%. Often you see much more than this. You want to target treating the cardiovascular risk by assessing their lipid profile and treating it, but we don't know what the target lipid level for CKD alone is. And you want to target reasonable glycemic control depending on the age and the quality of that patient's lifestyle. And you want to consider using medications that improve their quality of life. We try and get away from too much insulin and favor GLP-1 agonists to lose weight. The same with the SGLT2 inhibitors and oral agents. Insulin is still required in certain patients, but it puts on weight and tends to cause sodium retention and hypertension. Looks like that's a whole of practice approach. Get everyone involved. It was a bit of a no-brainer. Yes. Next. So take-home message. Screen those at risk. Don't be afraid to intervene early. Consider the color-coded advice you can get about the urgency of treatment and interventions, and always review their medication for appropriate dosing and appropriate benefit. And the sick day action plans, I think, are often overlooked, and it's helpful to either remind patients or give them some written advice. You can get advice from Kidney Health. They have lots of resources you can access, download. Quite helpful. Also access for patients to be supported through Kidney Health Australia. Right. This is where you can ask any question you like.
Thank you for participating. If you want to scan the evaluation code, please do so here. You're also welcome to follow Kidney Health Australia on Facebook, LinkedIn, and X. We really value your feedback as it informs future training. This is also a resource from the Australian Commission on Safety and Quality in Healthcare. So this is their Medicine Insight program. It's a national general practice data program run by the Commission. It supports quality improvement, clinical decision-making, and research in primary care. So they've recently released a GP snapshot for chronic kidney disease detection and diagnosis. So that resource will be emailed out to you also after the webinar. And the next webinar will be on the 10th of September. It'll be about managing chronic kidney disease alongside other chronic conditions. Thank you very much for your time tonight, and we hope the webinar was valuable to you. I'll just end the event now. Thank you everyone for your time, and thank you, Dr. Irish, for your time and knowledge in contributing to this webinar today.